Okay, I think that's it. We will get started. Welcome, everyone. Thanks for choosing our session. We're happy to see you. I'm Erin McGinn, a technical director in the health practice at Palladium.
And I'm Michelle Weinberger, a senior associate with Avenir Health.
Together with our colleague Jim Rosen, a few years ago, we worked on a model to help explore whether subcutaneous injectable DMPA-SC would make a difference when rolled out in a country. So let's start with first getting your thoughts on what some of the features of DMPA-SC are that have caused people to call it a game changer. I'd invite you to put your comments into the chat box. Okay. Well, some of the things that people have pointed to have been the all-in-one injectable that it can be safely provided by community health workers and pharmacists, and clients, of course, can self-inject. And so this feature brings an additional method closer to communities and clients and increases women's autonomy. So at HP Plus, we wanted to generate information for country decision makers to help them understand if and how to introduce DMPA-SC to maximize this additive value. So please put your comments in the chat if anyone has any thoughts or has experience speaking with ministries of health and country partners like Missions or UNFPA what were their questions when they were considering whether or not to introduce or scale up DMPA-SC in their country a few years ago. Right, how much will it cost? So it's always probably the number one question most people have. Okay, so some of the questions we were thinking about were very big picture, not whether women would use it or is it registered or how to get it registered, but big questions like if you introduced it into a national family planning program, would it increase contraceptive prevalence? Or how should you structure that introduction to really maximize this additive value that it has? And what, as Michelle mentioned, what are the cost of introduction, and are there any cost savings, and if so, for whom? So we first started thinking through what would be the pathway in which DMPA-SC would impact service delivery. So the first thing we thought about, of course, was this increased access. Because of its simplified characteristics, it can be offered through more and lower level service delivery points and through self-injection. But the impact of this increased access really hinges on how widespread injectables already are in the country. And then also linked to this is the possibility of switching. So women, if they're using pills or condoms because it's very accessible, it's convenient for them, if this method was brought alongside it, they might switch to the 3-month method. So that might have some impact. Also, we thought, well, it's an all-in-one product, so maybe this might simplify logistics. If the country suffers from a mismatch between syringes and vials for DMPA-IM, then the all-in-one packaging would help with that. But if a country suffers from stockouts of injectables generally for other reasons like weak procurement systems, then this isn't going to be improved just through DMPA-SC. And finally, of course, we thought reduced discontinuation. There have been studies to show that DMPA-SC through self-injection, like with self-injection clients, they have significantly lower discontinuation rates.
So we developed an Excel-based model that uses a mix of country data from demographic health surveys, as well as some global default assumptions to explore these questions. The main feature of the model is that stakeholders really need to come together and articulate a vision for what introduction will look like. So for example, will DMPA-SC be available everywhere or only through certain delivery channels? And is the plan to roll out DMPA-SC alongside IM, or is the plan to eventually have a switch out so that the country would basically migrate its injectables from being IM to SC? The model then gives estimates of the changes to modern contraceptive use and method mix, as well as the possible costs, savings, and return on investments over a 5-year period of these different articulated visions of rollout. We were able to test the model in a few different country contexts, as shown in this summary table. In Cameroon and Nigeria, we worked with local stakeholders to develop scenarios and validate the data and assumptions. And then we also did desk applications in Malawi and Tanzania to be able to see how the model would work in a wider set of different contexts. As you can see, these 4 countries really vary in terms of the overall level of contraceptive use, the share of modern users who are using injectables, as well as the current provision of DMPA-IM. Most notably, we see that in Cameroon and Tanzania, there's pretty restrictive policies that don't allow community-level provision of injectables, whereas Malawi already has pretty widespread provision of injectables through CHWs. The planned rollout of DMPA-SC that was modeled in each country also looked different, as shown in the final column of this table. So before we look at results, we wanted to do a little poll to get a sense from the group of what they think our results might have looked like. So this poll is asking you to estimate how much increase in MCPR you think we found across these different countries over a 5-year period. So a very modest increase of less than 2 percentage points gain over that time period, up to a giant kind of game-changing increase of more than 10 percentage points over that time period. Just as a note, these are a percentage point increase. So, MCPR went from 30 to 35, and these are increases above and beyond any historical trends that we think might have already been happening in the countries without DMPA-SC introduction. So the poll should be up on your screen if you can click on the range that you think best represents what we might have found. Great. So it looks like we have a wide variety of answers from a few people thinking that there are fairly conservative or modest increases in MCPR to a few people thinking we saw fairly large in that 5 to 10 point range. So let's take a look at the actual results. So as you can see, we found really modest increases in MCPR in most countries, ranging from just 1 to 1.5 points in all countries except Tanzania. I think what we really found with this model is that how much of a game changer DMPA-SC would be is highly dependent both on the country context as well as the vision for introduction. And I think this can best be seen through the larger impact found in Tanzania. So Tanzania is a country where there is already kind of a sizable amount of injectable use, but where those restrictive policies meant that access to injectables was fairly limited. And what we modeled was essentially growing access by allowing DMPA-SC to be provided both by CHWs and through drug shops. And so that kind of combined baseline situation with a really big change in terms of access led to that larger increase. So again, even in that context, 4 points is fairly sizable, but maybe not the game changer nature that in the early days of DMPA-SC, I think some colleagues had been sort of thinking about its potential role as being much, much bigger. But of course, whether or not DMPA-SC is a game changer depends on how we measure success. And we recognize that there are lots of important impacts beyond MCPR that we want to be thinking about. So even in contexts where change in MCPR might be limited, there are other benefits that we want to capture, things around improved autonomy or better improved user satisfaction that are really important. Though these are challenging to measure and not something that our model captures. But our model is able to quantify the cost savings associated with DMPA introduction, looking both at savings to the health system as well as to clients. For clients, these savings are largely opportunity costs related to travel and wait times. And as you can see, aside from Malawi, we found really significant savings for both health systems and clients, and often more so larger savings for the clients. And so these are important messages to say that even if we don't see that game changerness around MCPR, there are these other areas that we want to look at. This graph shows us the relative contribution of each of the pathways that Erin talked about earlier to the change in MCPR. as with the overall impact, we see that where that impact comes from varies largely across countries, again, due to the different contexts and the different rollout plans. But generally, we found that increased access and reduced discontinuation played the largest role. That simplified logistic pathway, which is shown here in blue, we didn't really find to be that significant across different countries.
So again, what did we take away from this? Well, first of all, we did feel that this model can be helpful to guide stakeholders when they're developing their introduction or rollout plans, either to address their expectations or to help them think through what would be the policy and system changes they need to really maximize the value of this method. So we worked with the stakeholders in Nigeria as we were piloting this during their development of their 2018-2022 DMPA-SC introduction and scale-up plan. So it's actually incorporated into that document. And then once the model was finalized and disseminated, we found out that someone at the UNFPA Pakistan actually used it during the process of drafting a 5-year scale-up plan for Sindh province. And as Michelle mentioned, the impact on MCPR, obviously in the vast majority of cases, will not be what we would call a game changer. But by conveying accessibility and cost benefits, supporting women's autonomy and reduced discontinuation, these are still really important changes that we need to bring into our family planning programs. Finally, we'd also like to just mention, we think this approach could be adapted to think through and model how other new methods might impact an FP program, such as the Kaya diaphragm or the hormonal IUD. So we have a few minutes for question, answer, or discussion. I do want to acknowledge Geeta had put in a good comment about, or question, if the uptake of IM is poor in a country, does it make sense to consider introduction of self-injection? That's an excellent question. It really depends on the country context. It might be a chicken or egg scenario. If access to IM is not easy, if it's far to go to a clinic or a health facility, then that might be the reason for the lack of uptake. And so one could pilot it and see, okay, if you bring it down to community level, do women access this more? But if it's just not a method that people like, for whatever reason in that country context, they prefer a different method, then you're right, spending a lot to introduce it might have marginal benefits. So it really depends on the country context. Any other questions or comments from anybody else on the line?
For those who in the poll thought there would be a larger increase in MCPR, maybe if you're willing to share some thoughts about sort of what went into your thinking that and your reaction to seeing the results that we found that were I think largely much more modest than maybe some of those anticipated gains.
Hi, this is Tara Sullivan from Johns Hopkins Center for Communication Programs. I had been one of those people that thought it would be higher, and I think it's mainly because it's been viewed as the language that you used as such a game changer, and it also seemed like in the time of COVID that you would have seen greater increases. So that was, maybe they're delayed or just haven't come through yet, but that was my initial impression.
Great, and yes, I will say this work was all done pre-COVID, which I think is a great point. That I think there was, though again, I don't know how much we're seeing this yet, but I think there was a sense that with COVID, maybe there would be sort of an extra push for that self-injection and for being able to have another method that doesn't require that face-to-face interaction with a provider.
Yeah, perhaps here we have learned that in family planning, things don't move very quickly, in in the sense that this method, I remember 20 years ago going to a meeting at JPIGO about this method, that this was ready for prime time, and that was 20 years ago. So it's slow to get out. And I agree with you, Tara. I think we're going to see more and more of it coming online and being available as people become more comfortable with this idea of self-injection and women's autonomy over family, like their own contraception. But I think it's going to take time. It's not only a system change, which takes time, but it's also a behavior change and a cultural change and things like that. So I think we're going in the right direction personally. I think added convenience around contraception and demedicalizing, if you will, are important trends that we should find ways to support. Geeta?
Hi, this is Geeta from Japaigo, India. Yeah, I mean, I was one of the people also who marked up that 5 to 10 and really thought it was the COVID context, which had sort of pushed people into a higher acceptance of self-injection. So this is more of really a comment and a reflection as opposed to a question. And I was, when I put that question down, because in India, we hear that, I mean, I'm sorry, can't give you more specifics, but the overall acceptance of the intramuscular version has been pretty poor, despite the fact that there was a very robust and very well laid out rollout plan, which was done physically, that required to be done, in a country which is the size of India. But women seem to have an issue with the prolonged periods of amenorrhea. And that seems to be sort of, having spread that message around within the community, which says, it's just going to stop your periods and, lead to a host of other diseases, potential sterility, et cetera, et cetera. So are there any strategies, that you could point us to, which could really help to mitigate this effect? Thank you.
That's a great question. And I agree with you. I think when one looks at different countries and their method mix, you see that some methods are more popular or less popular than others for a whole host of reasons. And I think that a lot of this is based on the health system, what the health system is oriented towards and has available, and then also culturally. And I think it can be a catch-22. My personal opinion is that when women start thinking about contraception, they're asking their aunties and sisters and maybe the mothers too, and so, a trend begets a trend, right? So it's tough to break that out. I've done a lot of work around, trying to, what was used to be called underutilized methods of like trying to get people interested again in the IUD or vasectomy. It's a hard slog. But what I would say, so again, outside my current work, but I have, attended some sessions around, there's a new, what's called they're calling it NORMAL tool, which is an acronym, and it's a job aid to help talk to women about menstrual changes, that each method is, a lot of the methods induce menstrual changes, whether like it's the copper IUD, it would be more bleeding, or like you're saying, amenorrhea for other methods, and trying to break through those concerns. In some cultures, the amenorrhea of perhaps, whether it's this one or even the hormonal IUS, are actually what we would call like a positive, side effect or something that they actually like. So it really depends on culture, the culture and what women are used to. But there are efforts to try to improve counseling and communication around menstrual changes due to, various methods. So you might want to check that out. Just the acronym is NORMAL, and FHI, I think, has developed this tool, or at least hosted the sessions, the webinars I went to on it.
Okay, and with that, I think we're due back in our plenary session, but thank you everyone for joining and discussing.